My two colleagues from the League are at the back of the room, Nico Moshe, who was a president a few years ago for the League, and Gary Mathern, who was an editor of one of our major journals and also one of our strategic planning advisors for a number of years. So what we want to do is talk a little bit about sort of the issues for epilepsy that lend themselves to advocacy and how to go about advocacy. And one of the things we'll talk about is just sort of from a global perspective, and there are some common themes no matter where you are in the world that affect epilepsy that really reduce the quality of life and access to treatment. But those are kind of some of the points we want to bring up, and then think a little bit about how you can then become an advocate, or the themes that you should consider in efforts for advocacy. Now, the League that we're with is over 100 years old now, and it's scattered across the globe. All the colored countries are where we have chapters. There are a few more that have been added since this was, but it is truly a global organization, and it's dedicated to epilepsy and making progress in epilepsy on many fronts. And as you can tell, it really spans the globe from some of the richest countries in the world to some of the poorest. And what's interesting is we talk about that some of the themes that we deal with, they deal with in the poorest countries and vice versa. So we're going to touch on those points. The actual situations may be different, but the issues and the themes are much the same. So, and this is it. We have talked with a lot of the regions that we have, and everybody says these are some of the biggest issues that everybody faces. And the first one is just access to care, finding somebody who actually knows something about epilepsy. And you think that would be kind of not too much of a problem in the US or in Western Europe, but in fact that is the common theme everywhere, that people can't find somebody who really understands epilepsy and know what to do about it. Safety is a big issue. Epilepsy is associated with an increased risk for death, and in some countries especially, it's estimated that as many as 20% of the people with epilepsy will die as a consequence of their epilepsy. Prejudice and stigma is huge. In many countries, people work really, really hard to hide their epilepsy because it will limit their employment opportunities, it will limit their abilities to find a partner in life, and it will just also lead to a lot of social isolation. There are legal restrictions that go along with epilepsy in some countries. In the US, it's obviously with driving predominantly, and there are cultural biases about the causes of epilepsy. When we talked about the prejudice about epilepsy and stigma, we also really mean that there are people, even here in this country, people don't want to talk about the fact they have epilepsy because there's lots and lots of prejudice against them, and they work really hard to hide the fact. And that's in the issues of advocacy, that's a problem because we need some famous faces to come out and say, I've got epilepsy, it's been a struggle, but I've been successful. And to come out and say what the issues are that they're dealing with. And we don't have that. We have very few of them because most people just don't want to talk about it. And we heard that from somebody this morning. After a year with his girlfriend, he just said he didn't want to talk about his epilepsy. So, the League organized about 20 years ago now the global campaign against epilepsy. And it was a joint effort between the League, the International Bureau for Epilepsy, which is the organization for patients, and the World Health Organization. Its goal was to really increase awareness and information about epilepsy to both physicians and to patients. Get epilepsy education out there for physicians especially, but also for the public, and really to reduce the prejudice and stigma. And that's where they came up with the title for this global campaign, which is Out of the Shadows. Because people with epilepsy worked really hard to stay in the shadows and to hide it, and they wanted them to bring them out of the shadows. The four people who really were involved in this very early on were Ted Reynolds from the UK, Shicho Li from China, Hanneke de Boer from the Netherlands, and Leonid Prolipko was from Russia, who was with the representative from the WHO. And these are the folks who got this going, and there have been a lot of positive effects from this, although at any given moment it doesn't seem like anything's happening. If you look at it in the global scale in terms of we have made progress. One of the examples of this even began before the global campaign. In Colombia, they were really struggling with getting any kind of care to patients with epilepsy. It just didn't exist. They had no rights, and they could be treated badly by this system. And they then sort of initially said, let's get some laws just to protect their rights, but they did many attempts, and it just didn't work. So finally, they found a senator, and this is the important piece here. They found a senator who was somewhat sympathetic to the cause, would listen to them. And they took him around to see what the issues were for epilepsy in real life. And he then became an advocate for epilepsy within the Colombian Senate. And that one advocate, that one champion they had made all the difference, because there was now somebody on the inside who would speak to their cause and their issues regularly and be supportive of it. And they worked together with him to write some laws to protect patients with epilepsy, but that was still, they were just writing the laws. They hadn't gotten them anywhere. And so it took about 25 years and some 230 meetings with the legislators before they finally got a law that was passed. But the executive branch, the Treasury ministries, the social protection ministries, they rejected it. They didn't want to have anything to do with it. They didn't thought it was appropriate. And they went on and passed it. And that was only after Hanneke de Boer and Carlos Acevedo from the IBE came and spoke to the parliament in a national televised presentation. And that really helped convince everybody that something was needed. The law passed, actually it was a constitutional amendment. The president vetoed it, again because of the issue of lack of resources. They took him to the Supreme Court in Colombia where his veto was overturned. And so it became law, and it really has improved access to care and medicines. And I've talked with a couple of people I know from Colombia that said, has this made a difference? And they said yes. They've got things now that they never had before, and it all came because they had somebody inside who was advocating for them and who worked with them, but it took a long time. And I think one of the messages here is that just to get these things done, it takes a long time. And you also need to get somebody on the inside. And this was the guy who did this. Jaime Fandinha Franqui was just as a neurologist. He sort of started the Colombia and Epilepsy professional groups, and he was the really driving force. So it was one man from the outside who drove this, and then finding somebody on the inside to work with them. And that's what it took. And I can't emphasize that enough, though, is this persistence we heard, yes, in the last talk, and persistence, but then also having somebody on the inside to take your message and to help make it a reality. Some of the issues about access to treatment. This is one of the big problems everywhere. And talking with people here and talking with people around the world, access to treatment is one of the biggest problems they face. Access to treatment, though, means a lot of different things. Well, a lot of it, though, just comes from a lack of knowledge. Patients don't know what to expect. Nobody in the community knows what to do with epilepsy. And the truth is, most physicians don't know what to do with epilepsy. We get very little education on it. And if somebody comes with epilepsy, they just do seizure counts and that's it. And there really isn't a knowledge about that epilepsy, and that epilepsy is more than just seizure counts. It's a whole social issue. The economics and the cost of care. Sometimes they just don't get the resources, sometimes very basic resources that they need, because again, it's not a priority for them. Epilepsy, as it was in Colombia, just was not a healthcare priority in the country until it was made a healthcare priority. And then they got the support. In a lot of countries in the world, they just can't get the medications at all. I hear some people in Africa that when phenobarbital shows up in the country, the word gets out there and people go looking for it because they know they can get it, because that's often the only medication they can get. But that's the only one that's affordable in many countries. So that in other countries, it's a hit and miss issue. The other people, though, is that people just aren't willing to admit the diagnosis. They'll do everything they can to avoid saying, I've got epilepsy. And that's also true here. There's some people, when you hit them with the diagnosis of epilepsy, they don't want to believe it because there are all these rumors and prejudices out there about that. In a lot of countries, too, it's a beliefs about the cause of disease, which is less of an issue here in the U.S., but some people look upon this more as a spiritual or a psychological issue as opposed to a medical issue. And it also gets in the way of getting effective treatment. And there have been some good stories in the U.S., sad stories about the conflicts about beliefs of disease that led to delays in treatment. So the lack of knowledge sort of goes back to the awareness about it and access to treatment. Patients often don't know their treatments, or the only treatment they know about is the one that their primary care or maybe a local neurologist in the emergency room tells them about, and that's all they know, and what their options are. And this is the sad truth. Most physicians have very little knowledge about epilepsy. We were talking about this, whether it's 1 hour of education or 2 hours of education they might see in medical school, but that's about it. And mostly that's the basic science of epilepsy, not so much how do you deal with it and how do you diagnose it. And that's one of the big problems, is that most physicians know so little about epilepsy, they just don't know how to, when somebody comes with them with something that could be epilepsy, they don't even recognize it. And if things don't go well, they don't recognize it either and just try doing the same thing. As far as their epilepsy go, they know if someone's having a convulsion, it could be epilepsy, but all the others, the partial simple seizures, the absence seizures, they don't recognize at all. And some of them may be adequate for the preliminary diagnosis, but once things aren't going well, they don't know what the treatment options are. Patients don't, physicians don't, and patients get stuck out there. It's been a common problem, and physicians, some of the epilepsy specialists have often talked about the frustration for seeing somebody who's out in a primary care setting or community setting for 20 years with intractable epilepsy before they got to see an epilepsy specialist that made a difference. Even in this country, though, you know, all these issues are a problem. Medications are often expensive, very expensive. And again, even neurologists aren't very well educated about epilepsy. It's a sad but true statement. They rarely see a specialist. I mean, in Virginia, where I am, there are probably 25,000 people who have intractable epilepsy, and there are 35 epileptologists, and I can guarantee you that most people never see an epileptologist in there. And that's true for most countries, most states in the Union. The other problem is epilepsy is not considered a serious disease, and we'll come back to that. And for all the other issues, the physical problems, the mental problems that are associated with epilepsy, there's almost no support for that, and people don't know how to deal with it, by the special situations for epilepsy. So, in the U.S., now with the latest CDC evaluations, there's some 3 million people with epilepsy. Probably 800,000, maybe even closer to 1 million, may have intractable epilepsy. 40,000 deaths have been attributed to epilepsy in the U.S. every year. And as we were talking earlier in another group earlier today, that's the same number as breast cancer, but breast cancer is the one that gets the attention, and epilepsy just kind of isn't even talked about as an issue, a major issue for mortality. It costs more than multiple sclerosis and Parkinson's disease together. But again, they're the ones that are getting more attention because epilepsy really is kind of this silent killer. Care is fragmented. People sort of bounce from point to point. They go from one person who doesn't really understand it to another, and they really don't get to the people who can understand their problem and deal with it. So there are a couple places that I want to go through what people have done to help override that, sort of overcome some of these issues in terms of organized care and access to care and access to appropriate care. I said one of the issues is most people with epilepsy probably don't need to see a specialist because they're going to do fine with their first treatment, or maybe their second, and they'll do okay. But for everybody else, there needs to be a path, and there is no organized protocol for anything. So in Ontario, recently, last couple of years, they have developed an epilepsy care plan, and to deal with the 35,000 people or so who have uncontrolled epilepsy. Until 2013, when the plan was first developed and approved, care, like everywhere else, was random. Who you got to see, when you got to see, was much a matter of luck or your own initiative to find somebody who knew something about epilepsy, because otherwise, out in the communities, they wouldn't know anything about it. On the government level, there was also very poor understanding about the costs and the issues associated with epilepsy. It was not even an issue for them as a healthcare priority. So, after some time, they actually have set up a protocol. And that was partly due to this guy over here, Carter Sneed, who's actually originally from West Virginia, who decided he liked cold weather better. But he was the driver behind this with a couple of his colleagues to help move this plan forward. And Ontario, you can see, is down there at the bottom. It's probably one of the more populous, if not the most populous, of the provinces in Canada. And this is what they did. They set up an organized center, an organized system for care in the province. And there's a community level care, and then you have the district epilepsy centers where people are trained in epilepsy, trained in management, trained in diagnosis, and they will have video EEG monitoring, but not surgery. And then you have the epilepsy surgery centers, which are the greens that are in Toronto and London, Ontario, where they have the highest level of diagnostic capability. And they set up a plan about how people move through. So there's a provincial protocol from the time somebody has a seizure and is seen in an emergency department, and to how they work their way up to one of the specialized centers. And then patients can go back. And one of the other things, though, that's part of this plan is that they also have patients, when they have intractable epilepsy, they get tied in with one of the epilepsy support groups, so that there's somebody there at their level in their community who they can talk with about their epilepsy and find the other social issues, their social solutions to problems that they're dealing with. So there's a sympathetic voice and somebody who understands the issues that they're facing. And it kind of looks like this. On the right up over here, get this thing to work. Oh, I can't see that one. Anyway, you have the components of epilepsy care. Basically, basic assessments. This is sort of after you failed in your community, and then you can work your way into working up for epilepsy surgery. But down here at the base, there are the community epilepsy agencies that can provide all the support. It's all there, legislated, regulated in the system about how they do this. And this is young, this is new. It's now 3.5 years old. We don't have the results back, but at least at this point there is a structure for epilepsy care in the province, which is very unique to our hemisphere. But it's something to consider about how we get people to the care that they need, or the level of care they need, in some organized and planned way. And I think they've actually convinced them that they'll probably save money overall by doing that. So, the Philippines is a very different situation, in which there are very few neurologists. There's a couple of major centers in the country, but the issue is how do you get epilepsy care out into the rural areas? And one of the goals of the Epilepsy Manager Program in the Philippines was that care by somebody who knew something about epilepsy was available within an hour where that person lived, which is pretty impressive in terms of that. And certainly in Virginia we don't have that necessarily. But what they did is they took rural primary care physicians and very basics of epilepsy. How do you recognize it? How do you diagnose it? And how are you going to treat it? They actually brought them into Manila to sort of work on the epilepsy units, get in the clinics to see what's done before they sent them back. And they get annual retraining as well. So there they get people who actually understand a little bit about epilepsy out close to where the patients are, so they can then get the care that they need. And then if they need greater, they can then get into the epilepsy centers. About, I guess, 5 or 6 years ago, after some work, the Pan American Health Organization created a strategy. This is going to be important for here in the U.S. because the U.S. is a signatory to this. All right. Pan American Health Organization, which is the hemispheric branch of the World Health Organization, worked on a strategy. They wanted to make epilepsy a national health care priority throughout the hemisphere. Protection of human rights, and get access to care through integrated care networks, access to medications, and just make sure that the physicians and patients knew about epilepsy and what to do. These were the goals. All right, this is the whole plan behind this. So every country in the hemisphere signed on to this, which was a great thing. And what it has allowed is at this point that they have had open discussions with the health ministries and the ILE and IVE chapters. And talking with them, some of our colleagues in these countries have said that they've gotten calls from their health ministers now that they had never received before, simply because they were encouraged to act with one another, and introductions were made. And this legislation, or this agreement, this treaty, if you will, has opened that door. They're putting out mentored courses and satellite symposia for primary care meetings now. That's become a goal. And there are several courses in Latin America in which they're reaching out to primary care physicians who are actually signing up to take this to actually help people learn the basics about epilepsy. Things like this have actually been done in parts of India as well. They're making it easier to obtain seizure medications. The WHO has an essential medicines program, and those 4 seizure medicines are part of that. So these countries can get these medicines at the lowest possible prices. And we're looking to sort of see how this is progressing. Some countries obviously progressed better than others, but I think it's been important because it raised the visibility of epilepsy and gave people at least an idea of what the things were that were needed to make progress. In the US, in 2012, there was an Institute of Medicine report on epilepsy. And the Institute of Medicine is sort of a think tank in Washington that actually prepares reports for Congress, among other things. And they looked at epilepsy and just to see what should be done. And what you see, though, is actually very much the same thing. They look at the clinical needs, talk about developing comprehensive care networks, improving education. See, this is the same thing that's happening in the third world as well. Develop prevention programs, improve the diagnosis of epilepsy, and also the coordination of services. One of the problems that they heard from many of the patients as they were going around getting testimony around the country was that patients were spending most of their lives going from one specialist to another. For someone who had some special needs, with a respiratory therapist and a physical therapist and their neurologist and the counselors and a variety of things. So they were spending all their lives just caring for this person who had epilepsy. And where it would have been simplified if the services were all coordinated in one place. So these were some of the messages that they got from the patients. It came out with great fanfare. Now, the reality is there was nothing earth-shattering in that report. It was all pretty much the obvious that we kind of already knew. But the important thing about this report is that it's a third party that's coming and taking an objective look at this and saying, you got a problem here. And these are the issues that the patients are dealing with that need to be addressed. And so we can now use this as we've sort of said, as sacred text to go around and show to the authorities and say, this is something, look, the Institute of Medicine has said, this is important, this is what we have to do. So it's a good starting point for discussions about what needs to be done for epilepsy in terms of on a national health care priority protocol or however the approach goes. This is a good starting point for opening that discussion about what's not being met with the Institute of Medicine report now. So that gets in, though, what needs to be done. So the unmet needs are all well described. There's no mystery here in terms of what has to happen. There's lots of this. The needs vary across the countries, but even in the U.S., the needs are huge. The leagues are developing levels of expertise, and we want to continue to do that. But the big issue is here is the changes, in terms of changes, it only happens when the patients and physicians work together to have health systems recognize the needs. Because if people don't talk about them, don't advocate for those needs, nothing's going to happen. And it's a partnership that we need to be working on to help make this move forward. The other thing is to break the needs down into small steps. Just like they did in Colombia, they sort of broke this down into very simple issues that then they can build on. And that's what we have to do, is understand what are the things we need first, second, and third. You have to create priorities so that when you go to a government agency, when you go to a congressman, you can say, this is what we need that can be put into a law. And you have to have those partners there, just like they did in Colombia. So these are the issues that remain. And these are the ones that we have to be able to address. But again, it's sort of how do we do this? And the important thing is that the epilepsy community comes together as a whole and says, this is our priority. The problem we run into is, and it's understandable that every diagnosis, every cause of epilepsy has its own advocacy group. And if they try to advocate for something in Congress about doing this, but everybody's going, they hear all these syndromes. They hear Dravet syndrome, Lennox-Gastaut, and hypothalamic hamartoma. All these things are very good and important. But in terms of changing the system, it's not nearly so effective as if we go in and say epilepsy needs this. And we then have to decide as a group, what is it that epilepsy needs? What are our priorities? What can be done through the legislative process, through the regulatory process to make it happen? Does it have to go through insurance companies to make sure that they're the ones that say, this is how we're going to handle epilepsy care in a protocol that we can agree on? All of those things become important, but we have to decide what direction we want to take, and we have to find our champions who are inside to work with us. So that's the spiel here. And the question then to you all is, what do you think, what should the priorities be, and what's your experience in advocating for epilepsy, and how should we go forward with this?